I'm an NHR clinical lecturer who is coming very close to the end of my training in the next 6 months. And I have, in the last year, been involved in the setup of a big randomised controlled trial and also some smaller ones. So I thought I would talk you through my kind of perspective of that, which will lead quite nicely into some teaching after that. Oh, hang on. Oh, no. How do I change my slide, do we think? There we go. Okay, so what is a randomised controlled trial? So we know we've all seen this.
It's changing for us.
Oh, has my slides not changed? Oh no, they haven't, have they? That's weird.
We can just see the editing view.
Okay, hang on, let me have a look. What about, that might be better. I think it's that Mac thing, isn't it? Where it doesn't necessarily show you the slides very well. Cool, okay. I'll have to do it in that view. Is that all right? Can you see that okay? Cool. So what is a randomised controlled trial? So if we look at our nice hierarchy of evidence for effectiveness of interventions, we move through a series of different types of pieces of paper that move from just anecdotal evidence all the way through to a nice systematic or review with a meta-analysis of a randomised controlled trial. And I think as a trainee, where we quite often sit are in this top left-hand corner. So we might do case reports, we might try and get published, quite often get them into conferences. I know everybody that does respiratory has just been desperately trying to write up case reports to get into the ERS conference at the moment. We might take it a little bit further and, you know, we've come into a job where we might be there for a year or so and there's been a series of cases. So you might have a case series and you might be involved in writing one of those up. But then this is normally something that's pulled through from the consultants and their bank of patients. And they've gone, actually, I want someone to write this. Do you want to come along and help? And so that's fine. You might get that as well. And this gives you that kind of a little bit more than anecdotal evidence, but it definitely is still on the anecdotal side. And then you might have a case control study, and this is something that you probably are going to see as a trainee if you are doing an ACF or you take some time out to do maybe a master's. And again, it's normally dependent on what your supervisors want to do. They've probably found you some money to come and sit and analyse some data. And then the big thing that you might do as a trainee, if you've got a couple of years out and you've got your PhD, is you might be involved in one of the big cohort studies. So this is in the bottom right hand corner, is one of the ones that I do talk about quite a lot when I'm talking about air pollution research. So there's big birth cohort studies from Europe that we've pulled a lot of our exposure information from. And these are great because what they mean is they've got a bank of evidence that's there that we can all go in and take another bit of message out. I'm thinking at the moment about whether we can set one up in East London. But these are all good, and these are all things that we can get involved in as trainees. But one thing that, you know, we're always told is the randomised controlled trial is the thing that you want to be involved in. They're quite difficult to get there because they probably need quite a bit of money. And one of the RCTs that probably spiked my interest the most in research as a trainee was this one. And the reason for it, so this was called the FEAST trial, and it looked at fluid boluses in Africa with severe infections. And the reason it spiked my interest the most in research is because the trial actually ended early and they had to cancel the trial about 2/3 of the way through because it had completely the opposite impact on mortality to what they expected. So they thought they were going to take these fluid boluses, they were going to make kids much better, because we've shown that in the UK and in America, if you give fluid boluses in critically ill children, they get better. The problem with this trial was probably because of the significantly different perspective of a group of patients that they were dealing with, but also these words here, resource limited settings in Africa. And so I was like, well, hang on, so they've done this big trial that's been funded, it had a lot of money behind it. It was effectively a negative randomised control trial, but probably the opposite of a negative one. Normally when we say negative, we mean that they didn't find a difference, whereas they actually had to end this one early. And it probably was the thing that prompted me to think, actually, what other questions can we answer in paediatrics? What can I get involved in? And I remember seeing this when I was a junior SHO, and it really was the thing that probably prompted me to think about a research career. And then this is the study that we're setting up at the moment, and we've had green light. We started it finally about a month ago. It's called the Blipper trial. So what I'm going to do is walk you through the Blipper trial and just explain my role in it and how I got involved in it, and just explain how it works. And it's a nice overview of a randomised controlled trial. So the Blipper trial stands for Bacterial Lysate in Preventing Asthma. It's an NIHR funded study. Oh, hang on, I'm breaking the screen. NIHR EME funded, lots of money behind it. And the theory behind it, so the question we wanted to ask is, we know that bronchiolitis is common. We see it in lots of babies. We work in paediatrics, and we know that it's a common illness. But we know that severe bronchiolitis, and in particular RSV positive bronchiolitis, is a risk factor for developing preschool wheeze. And then there was some other information that said, well, actually, if you give some bacterial products, so lysates, so basically bits of mushed up bacteria, this could potentially prevent preschool wheeze. So the question that went to the funders and the group took to the funders was, okay, fine, we want to see if bacterial lysate prevents preschool wheeze at a certain age. And this is a multi-site study, so it had lots of collaborators, researchers that are very high up and have been doing lots of research in the respiratory world. And this aim of the study, it sounds like not very many words, and it's basically what I've just described. But this, I've been involved in this since the setup. I'm not involved in the application or the funding, but since we got funding for it, just because I was, to be fair, lucky, and I work in the research group where it was going to start, I've been involved in it since the start. And we had to come up with the aim of the study and the research question. And this one set of words here, I think, took about 5 different meetings and about 7 different connotations of the protocol, just to get us to work out exactly what this succinct question was. I'd never been through this process before. I'd written protocols for research studies, cohort studies, and case control studies, which were quite easy to do because they were much easier to articulate, but also they involved a lot less people. So it was a real learning experience going through this kind of how you come to work out what your main question is. We then had to think about the logistics of the study, while some of it made kind of simple sense, so population quite easy, 3 to 12 months. The intervention is quite easy because we knew what that was. Comparison, so we are a double-blind controlled trial, so it's placebo, we don't know which one anybody's getting. The only people that are unblinded are in the case of adverse events. And it's a multi-centred RCT, so it's at lots of different centres. We've got 5 in the UK and 1 in Australia. It's double-blind, which means nobody knows who's in either group, and it's placebo-controlled because we're using a placebo. And then we have to move on to the next bit of the protocol writing, which was the eligibility, which the people that are going to take part in it, easy, straightforward. Bronchiolitis, we had to think about a time, think about technology in terms of contactable by telephone, but then we had to think about the exclusion criteria. And then this was a debate between the PIs on the study, in particular the ones that had experience of dealing with bronchiolitis, and also the risk factors for preschool wheeze. So anything else that could be thought of, we probably needed to remove it. So things like prematurity, clinically significant neonatal disease, or any chronic conditions, and whether they're on other medications. I put in salbutamol there, but hopefully if they're under 12 months, they won't be on salbutamol, which was, again, something that I would then bring in after I'd been in the meetings a few times, was those kind of on the shop floor, what do we do on a regular basis? Because you'll often find that the people that are PIs and CIs for big studies are not as on the shop floor as some trainees, and actually trainees' views are really important and could be really helpful. This is our little thing about the treatment. Again, I was amazed how much debate we had to go through with this, and how we tried to decide what day of the week we would give it on and things like that. But also this was then the opportunity to get involved with the PPI. So we've got a parent panel that we go out to, and we talk through most of our bits and pieces with them as well. And again, that was something that I really enjoyed being part of, because it was actually getting parents' views on the study. we had to talk about what was on the packaging. What it said on it, where it said it, where the sponsor things came from. Learning all these new things about how there is somebody that will make the medication, there will be another person who delivers the medication, and there'll be another pharmacy where the medication gets sent to. All these bits and pieces that you don't really think about when you're thinking about where a trial starts and ends. And then the participant flow. So moving from this kind of basic idea of how our patients were going to move from eligibility through to being part of the study. And again, this affects which groups they're in, how the randomization works, the input of all the different parties, and all the different groups that were involved. And then these are the processes, and these are all the things that I probably knew vaguely about from my previous research involvement, but I don't think I truly understood how many panels and how many people were involved. So I wrote the initial protocol, and it doesn't look like the protocol that I wrote initially. We've got the trial steering group, which are people that are separate to the trial that help run the trial. We've got our data management committee, which again, separate to the trial, that check on our data. The PPI panel that I mentioned. The ethics approval was actually relatively straightforward in relation to other studies, and that's probably because it's been so many connotations and so many different people looking at the protocol in advance. Actually, by the time we got to ethics, the HRA and MHRA process were actually relatively straightforward. There was just a little bit in terms of the labs that was a bit complicated. And then once you've done this bit, you then still have to get all the internal approvals, all the sites. So we then are now still waiting for each of our sites to be set up. So we're set up at one site, but actually the other sites aren't open yet because we have to go through another set of approvals. And I think the reason I've kind of talked you through it in terms of this trial is that I felt that I'd done quite a lot of involvement with lots of these processes before, but I found it quite overwhelming as to where everything was. And I think as a trainee, you quite often come in once a study is completely set up, if you're doing a short period of research and you're just going to be doing a bit of it. So you might be doing like the review of the data at some point, or you might be doing a specific bit of lab work that's taking samples from a bigger trial. But actually getting involved right from the beginning gives you a real insight into how a trial is set up, how one runs, how many people are involved, how much writing, how many meetings it takes. Interestingly, we set this all up during the pandemic, so a completely different setup, I'm sure, than to what we previously would have set up at RCT on this scale, in that I've never met about 2/3 of the people that are involved in it because they're not here, or at least not in real life. So I think randomized control trials are really interesting. They're good to be involved in. They're difficult to get your foot in from a trainee's perspective, but if you're in a research group that is setting one up, ask which small part you can do of it and how you can move forward and get involved more in research. Fab. I mean, that's it. So that's my talk through. If anybody is there that wants to ask any questions, I'm ready. I will try and stop sharing my screen, hopefully. Nope. I don't know how to do that. Oh, this one? No. Ah, cancel. No.
No.
Hey, you know, oh, there we go. Ah, perfect. Someone else has stopped sharing. No.
I can still see it. It's
Yeah,
all right.
I know. Oh, hang on. Here we go. There.
Yeah, done. Abby, you had two little kind of thinking of a trial vocab. You mentioned a clinical trials unit. Can you just explain what that is?
So most universities have got something called a clinical trials unit, and it's normally a pragmatic clinical trials unit. So they are a separate department that you cost into your, basically they'll bring your trial manager in and they'll do your database design. They basically do the logistics side of a research study. I've realised you can't see me talking. There we go. They will do your logistics side, they will do all the setup, they will do all the management side. They will do it from a pragmatic perspective. They are not usually medical, although you can do placements with PCTUs, and there are NIHR funded posts that you can apply for that are set within a PCTU. But they basically take away all that management side of things, which I'm very grateful for our trial manager. She is absolutely amazing, and I can't, it's her full-time job is just to run this one trial.
That's really helpful. The other question I was just going to revisit that you touched on already was, how does a trainee get involved in the trial? And I like that you went a little bit, emphasized how valuable it is to be involved at the planning phase of a trial to really understand all these relatively complex processes that are part of it. You got any more?
Yeah, I think I think it's actually quite difficult if you're not already in a research post to get involved. It's worth looking out at what departments are around, and this is a massive randomized controlled trial. There are other ones that are much smaller, and at the moment I'm setting up a site for a German study at the moment looking at a Wheeze device, and that's much smaller, and actually that's going to be me and another trainee looking after that, and that's much easier to do. Something on this size, it's being around and being in a research group at the time, and there are, you know, lots of research groups around, and being keen and being active, and, you know, everybody likes having somebody else on board to help write things and review things. So I think it's, if I had my ideal training world, everybody would be thrown out of training after ST3 and have to do a year in something else, and I would think that the majority should do some research time in a research group, in which case you would just be thrown into whichever study trial they're setting up at the time. When I say thrown out, I mean thrown out and then brought back in, obviously. Because
wonder if anybody else has any questions.
I just have a quick comment. I think it's really difficult as a trainee because you're not in one place for a long time. The gestation period for doing a trial is many years. You know, usually you start with a pilot possibly, and then you may then progress to a big trial, etc. Just my own example is I started the pilot trial in 2013. It's 2022, and I've just finished recruiting to the main trial. So it takes a long time, and I suppose that's one of the biggest challenges for trainees to become involved is you're not there in the same place for a long enough period of time to see the whole cycle or even part of the cycle. So it's really something maybe we need to think about how we would do this. You know, if we are thinking of research training as part of, you know, general training.
yeah, I think that's exactly it, because I mean, I've been very lucky. I did my PhD in one research group which started in 2014, and I've stayed with that research group. I've dropped back out into training. I've then had an ACL job, and so I've been within that research group, which is really, it's worked. But you're right. I mean, even this has taken us from the initial application went in 2017, and it's taken us 2.5 years just to get it set up. So it's, yeah, it's definitely not something you can just do alongside that easily, but I think we should be thinking about ways to get trainees involved at all stages.
And I suppose on that, as Eva, I'm sure will mention in a minute, the sort of pan-London research as trainees working together is how you can start to get those skills.
Yeah, the idea exactly that as you rotate, you might be working on the same multi-site project is, of course, one solution that will apply to many trainees in terms of longevity of postings. And again, signposting you to REACH, which you'll hear lots more about, a trainee-led research network that's coming soon. Any other questions from anyone? Otherwise, we can let Abby go. She's got other things to attend, and we're very lucky to have Ram here as well, who I'll let him introduce himself and share his slides.
Thank you. Thanks, Abby. Just a quick sentence of introduction. I'm a consultant in pediatric intensive care. I have been part of the CATS team for several years, but doing a lot of active research, particularly clinical trials. And I'm currently in Imperial College working at St. Mary's PICU, which I have been doing for several years as well. But what I wanted to quickly talk to you about today was not so much about a particular trial or a particular finding, but more general talk about RCTs in general. And it's a big topic. I can't cover the whole of RCTs, but what I thought I'd focus on is really something that's very small and bite-sized, which is choosing or selecting the right question for an RCT, and then talk to you a little bit about what randomization effectively is and what it does. So it's not going to be a comprehensive talk on all things RCT, but you can see that each of these topics is going to take a long time to cover. But what I'm hoping for you to get out of this is not so much that many of you may not ever want to do an RCT or ever do an RCT yourself. Some of you might, but actually all of us read papers, and all of us are asked to appraise papers, including RCTs, which is obviously a high level of evidence. And when you actually read a paper, when you appraise a paper, it's important for everyone to know what the underlying sort of basic ways in which the RCTs have been designed. So that's the sort of angle I'm going to try and take. So let me just share my slides. Can you see that?
Yes, can see it.
Perfect, perfect. Thank you. So, so as I said, I'm just going to cover. Right, let's move this. So just 2 or 3 topics really on RCTs, and I just wanted to start by saying, they are called trials for a reason, because they are trying, and because they do take a lot out of you, and that the right question is quite important for an RCT, but also I'll talk to you a little bit about what the principle of random allocation is and why it's so important, why everybody focuses on it so much, and also talk to you a little bit about any threats to randomization. So those are the only 3 things I'm going to talk about. I'm not going to go into the nitty-gritty of how to do a trial. So starting from the right question, not all questions are amenable to an RCT. RCTs are really powerful tools, but they are really high maintenance. And I think you probably heard from Abby how high maintenance they might be. They are costly, they take a lot of effort, they involve a lot of people, and you need a lot of resource thrown into it to make an RCT work. So I'm just going to plug my laptop. And essentially, it's not for the faint-hearted. It's not for someone who doesn't have enough resource and time and funding to do an RCT. So the selection of the questions is really key. You have to select the right questions that work for an RCT. So the question really then is, what are the questions? Well, primarily an RCT is a tool that is intended to compare 2 things, or more than 2 things, but essentially it's a comparative question. So every RCT addresses something versus something or something else. So it's a comparative question. So your questions have to be amenable to being a comparative question. Now, which is why we call one of them the intervention and the other thing the comparator or the control. And the control or the comparator, as you probably just heard Abby just speaking about her trial, is either an active control or a placebo control. So placebo control, i.e., it doesn't have any specific activity against whatever you're studying, but it's something that people think you're giving and therefore can be amenable to some kind of blinding. An active control is not placebo, so it's also got some activity. So you're comparing, say, for example, amoxicillin against azithromycin. So both have activity, not one of them is not inactive. The other thing to say about comparators or controls is that you can have standard care as your control, but recognize that standard care might be variable across various sites. And so if you have a multi-center RCT, standard care might mean something in one place, something else in another place. So you're really not comparing a single comparator, but a merged, bunched up set of comparators. So those are the sort of key things to think about when you frame a question or develop a question for an RCT. Primarily, it's a comparison, and secondarily, it involves some form of intervention and comparator. You have to choose what your intervention and comparator are. So I was hoping that we could have some interactivity and people may be able to just chat into the type into the chat box. Can you specify whether this question, or this, I've just taken titles of papers, is this a question that is amenable to a randomized controlled trial or not? I'm hoping everyone can type into the chat.
Or feel free to shout out if that's easier. There's so few of us.
Yeah, that's right. Just shout out if you want to shout out. I can't see all the attendees, so so just shout out or type.
Yeah.
Oh, it's a comparison, isn't it? Yes, we're getting
Yeah.
yeses.
Yeah, good. Okay, we're getting yeses. So this is a comparative question. So we are comparing in this title, and I'm not giving any more details, just the title: high flow warm humidified oxygen versus standard nasal cannula oxygen for moderate bronchiolitis. Okay, right. So now that we've kind of eased that question in, what about that question?
No.
No. Yeah. Okay. Got a couple of no's. And the reason it's a no is because
No comparator.
okay, so this is more a descriptor, isn't it? This is a question here is, what are the risk factors for PICU admission and death among children with COVID and PIMS-DS? They're not saying what is the comparison between, you know, PICU admission rates for patients with COVID versus non-COVID or something. So even that might be a comparative question, but we're not really seeing that here. What about this? Number 3.
It could be if you compare to something. Yeah.
Yeah, so it could be. So it's a bit tricky, isn't it? You don't really know from the title if it's an RCT or not. It's some form of intervention, but if there is a control, as Eva's just typed in, then yes, it could be a randomized control trial question. But if it's not, a concurrent control, and that's something that's very important because you could have a historical control. So this could be a systematic intervention of, say, washing hands compared to a time when you did not wash your hands. But that's not a contemporaneous control. And so therefore, really, it isn't, if it is that way, then it's not really an RCT question. I can tell you this particular one is not an RCT. This was a more historical comparison to a period of time when there was no intervention. So this is a more a bundle of care type question. Okay, so moving on to another exercise. This is the interpretation from a trial. All these are real trials and all these are pediatric trials. So these are all important trials we all should be reading and be aware of. But this is the interpretation. So I want you to tell me or type in the chat what the comparisons are, what the intervention is, and what the comparators are, if there are more than one. It's awfully silent of you. I'm sure someone can say something or type. Yeah, so antibiotic impregnated catheters versus normal catheters. Yeah, okay. Someone's typed in standard heparin and antibiotic impregnated catheters. Yeah.
You got
So
two controls, or
yeah. Sorry.
Yeah, there are two controls here, or is it
Yes.
multi?
Yeah, exactly. So I suppose what I wanted to show you here is that a randomized trial does not necessarily always mean comparing A versus B. It could be A versus B versus C. And what you're seeing is antibiotic catheters that are compared to standard catheters, i.e. nothing, or heparin, bonded catheters. So this is a A versus a B versus a C trial. The interpretation of these trials and how you design them is a bit more complicated, because you have to work out whether you're comparing antibiotic catheters versus everything else, or antibiotic catheters versus standard catheters, and then antibiotic catheters versus heparin catheters, and so on. So won't get into the details of it. I just wanted to show you that the question might not just be a simple A versus B comparison. What about this conclusion? Sorry, the first trial, just if you don't or haven't spotted it, was the CATCH trial, was published in the Lancet 2016. This trial, number 2, is MEND's trial, which was published, I think 2 or 3 years ago. So what's the intervention and what's the control? Yeah, so intervention is melatonin and the comparison or control is placebo. And so this is just something to illustrate that this is a placebo-controlled trial. So they're not comparing melatonin with, I don't know, diazepam or something. They're comparing melatonin with nothing, effectively. Okay, and what about this, which was published in JAMA? This is called a CAPIT trial, community-acquired pneumonia trial. So what's the intervention and what's the comparison? Yeah, so there are 2 different comparisons on there. There's a dosing comparison and then there's like a duration comparison. So there are two types of questions. So one is comparing low dose or lower dose outpatient oral amoxicillin, which was compared to higher dose, and a 3-day duration compared to a 7-day duration. So essentially, this is what we would call a factorial trial. So there are 2 comparisons or 2 randomizations. One is low dose versus higher dose, and then a 3-day versus a 7-day, but the patients are the same patients. So this is a 2-by-2 factorial trial. So you get randomized to low dose versus high dose. Then the person who gets randomized to low dose gets the 3-day randomization or a 7-day randomization. So just to give you some examples of these trials. So just moving forward, one of the ways, I think Abby showed you on her slide as well, one of the ways that people frame questions for RCTs and how national funders particularly like you to frame questions is in a PICO format, which I'm sure you know stands for population, intervention, control or comparator, and outcome. And there is often an S at the end about study design, but we are talking specifically about RCTs here. So the population is what is the condition, what's the disease, what's the setting, what's the severity of the patient group, what is the actual patient group. And while sometimes this is quite easy to say, oh, it is patients with bronchiolitis, that's often not enough in an RCT. Your question has to be specified much more specifically than just that. So for example, you might say all infants under the age of 1, as I think Abby showed you, was it 3 to 12 months, with bronchiolitis, seen in an emergency department with whatever severity you think you might want to apply, severe bronchiolitis. So that would be a specific way of describing your population. Just when you frame the question for an RCT, remember that framing the population is really important, because this is the population in which your results are going to be valid. These results that you generate are not going to be valid for the patient that you didn't include in your population. So you've got 2 choices. Either you restrict your population to a very small subset, or you restrict your population to a very general, all children with bronchiolitis. I don't care how old they are, I don't care how severe they are, wherever they present, ED, wards, PICU, don't care. So you could be as general as that. But remember then that your population is that population. The intervention, the question has to be quite specific about what is the intervention, how is the intervention going to be delivered, and how much of the intervention is going to be delivered. So for example, melatonin in this case, the MEND's trial, is the intervention, How is it going to be delivered? Is it enterally? Is it IV? Is it, I don't know, inhaled, nebulized? And how much of it is going to be delivered? What's the control? And exactly the same, because you have to compare. And the outcome is often the most tricky one to define for a question relating to an RCT, which is what is the primary outcome that you're interested in? This is obviously the desired goal that you want to change. So for example, you could see in Abby's trial, it was changing the wheeze, the proportion of children with wheeze after bronchiolitis. So you have to specify what your desired goal might be. That might be mortality, that might be length of stay in hospital, but it has to be important, meaningful, and what you want to change. And as I said, it's not just important to us as clinicians, but also important to service users. So PPI or parents and public have to be closely involved with trying to understand what the relevance of your outcome is. But also it might be to policymakers. The NHS might be quite interested in finding out what your primary outcome is, if it's very likely to lead to a lot of expensive or less expensive changes. So how do you find out what the right questions might be that are important for people? You do surveys and you ascertain through surveys what people. So these are 3 examples. So the first one was published on November 21, so only a few months ago. This is child health research, so general pediatric research priorities involving surveys of clinicians. The second one was published 3-4 years ago from the Peruki network, which is the emergency medicine network. And then the last one was published 1.5 years ago from the PICU network. And in this one, we asked priorities from healthcare professionals, but also overlaid the parents or guardians' perspectives onto that research priority list. So these are ways in which you can understand whether your research question for an RCT is important. And this is really important to do because you might have a great idea to answer in your mind for a clinical trial, but unless it has widespread support from a lot of people and is judged to be important, you may not get anybody to be interested or fund it. And I just want to kind of quickly conclude the question about the topic of question with this, which is that whatever you're studying has to have enough uncertainty associated with it that there is equipoise for randomization. So people often say, oh, you want to do a high flow trial? I would be really interested in participating. And when you say to them, it's a randomized trial, and sometimes you get high flow and sometimes you don't get high flow, people say, well, no, then I'm not interested. The purpose of randomization is clearly to allocate at random one intervention or control, and you have to have clinical equipoise to be able to randomize patients. And so you have to select a question that is often in our field, particularly pediatrics, is somewhere in the middle in the pendulum swing. If you go to people and say, I want to trial delivering magnesium sulfate through the intraparenchymal route for patients with asthma, it's likely to be very extreme. Nobody's going to have any interest in it, and people are going to say, oh no, not really. Let's imagine it caught on and everybody thought that was the best thing to do, and you were in position 5, then it means that everybody will want to do that. You might be in the extreme position where nobody will be willing to randomize, and you really want to select a question where people are able to apply their uncertainty and be able to randomize. And this is a big important problem when you try to do an RCT. You might have really important PICOs, but if they're not able to be randomized to, you will struggle. So that's the bit about the question. I won't go into too much more detail. We can have questions later, but just we're covering the last points very quickly. Random allocation. The whole point of randomization is that you or your friends or your colleagues or your registrars or nobody has influence on care between the control and the intervention. So here, I've just given you an example, is let's say you want to randomize patients to either having saturations of 88 to 92% when they're ventilated, or SATs of 94 to 98% when they're ventilated, and you're interested in finding out if it makes any difference to their mortality, then you want to randomize them to one or the other intervention or control, but you want that to be completely random and not influenced by anybody. So what does that mean? That means that if I just told people, why don't you just compare people that your SATs are 88 to 92 versus 94 to 98 without randomization, it's quite likely that patients who are much sicker, ex-prem babies, cardiac patients, and maybe because of some clinical preferences of the individual clinicians or the hospitals, that the patients who are in the 88 to 92% will be very different from the 94 to 98% if you don't truly randomize them. The observational studies that you see that compare, say, two groups of patients try very hard to try and get rid of this confounding. But really, you might be able to get rid of confounding by taking out all these factors. But what you don't know is that there's probably a whole host of other factors which are also associated with clinician preferences or with other ways in which these patients are different that you cannot take into account, that you don't even know about. And therefore, you can't account for it or adjust for it in the observational studies, which is why randomization is so important, because it truly means that you have no control, the clinician has no control, nobody has any control on which intervention or control the patient gets other than the randomization. So you'll often see, say, for example, this is an example from BIDS trial, you'll see a table 1. The table 1 usually tells you what the characteristics of the patients are who went into the trial. And you can see here, standard group, modified group, doesn't matter what the groups are, but essentially you would have a table 1 that says the age was X and the boys were, this X 60% and whatever. So let's assume that you have this question about, so in BIDS trial, it was a question of saturations over 90% for bronchiolitis versus over 94% for bronchiolitis, and you get this table 1. But what is important to know is that, well, you might think, well, actually, if you randomize, you get all these table 1 characteristics. Everything has been, roughly equal. You can see, food allergy, 3% versus 4%, antibiotics on arrival, 8% versus 8%. Look, they look really balanced. But what's actually more important is that all the things that you haven't measured in table 1 are also going to be equally balanced. And there may be hundreds of things different between these patients, which might get equally balanced by randomization. So you don't know the parental socioeconomic status, whether they've been vaccinated, whether they've had 5 days of symptoms or 3 days of symptoms or 2 days of symptoms. None of it is in the table 1. But actually, the process of randomization helps you to balance all the unmeasured as well as measured variables across the two groups. So you can be confident that you are really comparing two equal groups, even if you don't know a lot of the factors. So therefore, it's very important that randomization is done properly and correctly. And so that's why when you read papers, you see like a whole paragraph on how they randomized patients. First thing to say is that randomness or random allocation doesn't really work if you have small numbers. So you do need larger numbers. So I've just illustrated here. Let's just take 10 patients, you randomize them. You might get 3 males and 2 females in the intervention group and a reverse in the other group. But if you take 40 patients or 400 patients or 4,000 patients, the chances are that your groups will be more balanced. So the more the numbers, the more the balance will be. So you struggle if it's a small trial with small numbers of patients, and that is a problem for pediatrics. Not a lot of our patients have lots of, have conditions that are so common that you could have thousands of patients enrolled in them. So this is an example. I've just sort of given you an example quickly here of a small trial. This is not a real sort of published massive trial, but you can see a small pilot trial where they randomized 24 patients to lactated ringers, so balanced solution for fluid resuscitation, compared to normal saline, 26 patients. And you can see the small numbers mean that the groups are not that well balanced. The sex is well balanced, 46% females, but actually the age is not well balanced. But when you randomize thousands of patients, like you do in FEAST, which you saw earlier, you get almost magical equal balanced groups. So you can see here, everything seems pretty much comparable between these groups. And that's the whole point and the purpose of randomization. So in the next sort of couple of minutes, because I know we're running short of time, the robustness of the randomization is really very carefully looked at when you look at a paper, but also when you do a trial. The random sequence has to be computer generated rather than tossing a coin. because even with tossing a coin, you can get imbalances. And it has to be untamperable. It's not something you can sort of have in an envelope, say, where people can just open the envelope, have a look and say, oh, it says CPAP. I don't like CPAP. I'm going to put the envelope back and open the next one. It has to be untamperable with an online or phone-based or whatever else type of method where you can't actually predict. And more importantly, you need, especially with smaller numbers, you need to be confident that you can balance the numbers. If you don't stratify patients during the randomization, and these are things you will read in papers, stratification and block randomization. And these are two methods to try and help you with smaller numbers of patients to randomize patients appropriately into the same category. So this is an example. You've got triangles and ovals as the patient population in general. You stratify them by shape. So take the ovals and take the triangles, and then randomize within that group into blocks. So these are size of 4 blocks. So you say it's either A, B, B, or B, B, A. And so when you keep going through the randomization, the first patient is A, the second patient is A, third patient is B, fourth patient is B, fifth patient is B, sixth patient is B, and so on. And so this way, what you've done is you've sorted some things about the patient that you know into characteristics and then randomize them rather than just randomize them straight up, which might result in more imbalances. So this is an example of the first ABC trial that I'm leading. So you can see here points that we talked about. The randomization sequence will be computer generated, the block sizes will be variable, and randomization will be stratified by site, i.e. that if you have 20 sites, each site will have equal numbers of patients randomized, not equal numbers, but essentially each site has the potential for the patients to be randomized into the same ratio. So for example, if you have 10 patients in site 1, you should get 5 patients in A and 5 patients in B. Another site has 100 patients, you get 50 and 50. So you stratify by site and by age. So these are the sort of things you read in papers, and these are the things you should look at as ways of randomization. I'm probably going to have to skip through this really quickly, and I'm sorry about time. But essentially what I wanted to highlight here is what you probably already know about intention to treat analysis and something else, which is not intention to treat. What I wanted to show you is why people do intention to treat analysis. So here you have patients, and this is a mock-up of the first ABC trial that I'm running. So 600 patients were randomized, 300 patients randomized to high flow, 299 to CPAP. This is the randomized allocation. But what happens after that is people do all sorts of weird things. Like they say, oh, 6 of these patients were not eligible to the study because we discovered that they were premature and you didn't really want any premature babies in there. Or they say, oh, they're not eligible because they had already received some respiratory support for 5 hours beforehand, so I can't really put them in. And they only start the randomized allocation in a smaller number of patients than you want them to start, and they didn't start the high flow or the CPAP in some patients for various reasons. It suddenly decided that they wanted to start CPAP in 10 patients, and they intubated 15 patients, and so on and so forth. The reason I highlight all this is because intention to treat means the patients are analyzed as randomized within the randomized group. It's a more conservative approach to what you might find, and per protocol is analyzed as if they received the intervention. So for example, in this example, you would randomize the patients to high flow and CPAP and analyze their results as if they stayed in the group that they were randomized, which basically means that you assume 301 patients got high flow and 299 got CPAP. Whatever happens at the end, the primary outcome, you decide on the basis of these numbers, not what happened afterwards. You might say, well, actually, how is that sensible? Because only 270 people started high flow. So how can you even attribute the outcome to 301 patients? Well, that is the whole point of intention to treat, because randomization is such an important concept that you don't want to tamper with it. As soon as you know what the allocation is, if you start tampering with it by saying, oh, I don't think they're eligible, oh, I don't think I'm going to start high flow, I'm going to start something else, after knowledge of the randomization, you've introduced bias into your sample. And so the whole core concept of randomization is that those two groups are equally comparable and you don't mess with it. So anyway, so I'll stop there. And those are really sort of three key concepts in randomizations and randomized trials. So not all questions can be or should be addressed by an RCT. Randomization is a powerful tool for causal inference. The whole purpose of randomized trial is to understand whether A causes something versus B. And it's important not to squander this powerful tool of randomization in your analysis, so you don't mess up your analysis by not using the intention to treat analysis as your primary analysis. I'll stop there, and I'm sorry went over a little bit, but if there are any questions, feel free to shout out or type. I can stop sharing so I can see you.